Now let's talk about Gitelman syndrome. Gitelman syndrome is a defect in the early distal convoluted tubule. It is an autosomal recessive disorder. But first let's talk about the normal DCT. In the luminal site, there is a sodium chloride cotransporter which transport sodium from lumen into the cell. The energy that is required during this process is derived from sodium-potassium pump, which is located in the basolateral border of the cell, that pumps sodium out of the cell, creating a gradient, and that pushes sodium from lumen into the cell and takes chloride along with it. Since chloride is transported against the concentration gradient, it leaves the cell along the concentration gradient by diffusion. Calcium enters from lumen into the cell by passive diffusion, and it is reabsorbed in the blood in exchange of sodium. The reabsorption of calcium is mediated by parathyroid hormone. Magnesium enters into the cell by TRPM6 transporter. So thiazide diuretics which blocks this sodium chloride cotransporter. When there is a genetic defect of this channel occurs, that is known as Gitelman syndrome. Now let's compare this Gitelman syndrome with normal DCT. In Gitelman syndrome, there is a decreased reabsorption of sodium which will lead to hyponatremia. Decreased reabsorption of magnesium will lead to hypomagnesemia. Decreased reabsorption of chloride will lead to hypochloremia. And decreased reabsorption of calcium will lead to hypocalcemia. Now clinical feature. Clinically, we will find the features like salt wasting, which is hallmark for Gitelman syndrome, and also polyuria. As Gitelman syndrome typically affect children, so mother will complain of frequent diaper change or nappy change, which will suggest the polyuria. And we can find the signs of dehydration like sunken anterior fontanelle or dry skin, dry mucous membrane, which will suggest the dehydration. Due to dehydration, the GFR will be low and there will be high renin and aldosterone level. So there will be secondary hyperaldosteronism. In secondary hyperaldosteronism, there will be loss of potassium and hydrogen and reabsorption of sodium and water occur. Due to loss of potassium and hydrogen, there will be feature like metabolic alkalosis. And there will be gain of sodium and water. But in Gitelman syndrome, the loss of water is more than the gain. So the patient will be normotensive. Due to loss of water and electrolyte, you will find the feature like fatigue and there will be failure to thrive. We know that magnesium is lost in Gitelman syndrome, and magnesium is very crucial for functions of the parathyroid. So due to low magnesium, there will be low parathyroid, and this low parathyroid will lead to hypocalcemia and subsequent tetany. So we can diagnose this Gitelman syndrome by serum electrolyte, which will show the low sodium and potassium level and low magnesium level. In the urine, there will be low urine osmolality, but 24-hour urinary chloride excretion will be high and 24-hour urinary calcium will also be high. So this 24-hour urinary calcium differentiate this Gitelman syndrome from Bartter syndrome. In Bartter, the 24-hour urinary calcium excretion is low. And by this 24-hour urinary chloride excretion, we can differentiate this from diuretic abuse. In Gitelman syndrome, the chloride excretion is persistently higher, but in diuretic abuse, this will fluctuate, which means that diuretic effect, when present, the chloride excretion is higher, but when diuretic effect is absent, the chloride excretion will be low. There is no definitive treatment, so we can treat this Gitelman syndrome by replacing the lost electrolytes.